day to all of you. I shall be speaking on anesthetic challenges and renal transplantations. I am Dr. Raj Tobin, anesthetizing patients for surgery of kidney transplantation forms a major part of my clinical practice. So when we begin to discuss surgery and anesthesia for renal transplantation, foremost is the point that renal transplantations are neither urgent nor an emergent procedure, but still a time-sensitive procedure, and that should always be kept in mind while evaluating any patient for renal transplantation. Now, this is the classification of chronic renal failure as suggested by KDIGO in 2012. KDIGO is kidney disease impacting global outcome group. So stage 1 is a kidney damage with normal GFR, and stage 5 is what we call end-stage renal disease, where the GFR falls to less than 15 ml per minute. Now, what are the causes which lead to chronic renal disease? They can be congenital or acquired. Hypertension, uncontrolled hypertension is one of the causes. Vascular disease, which can be autoimmune in origin or as a result of uncontrolled diabetes mellitus. Glomerular diseases, primary or secondary, mostly infective in origin and most common cause in our country. Cystic kidney diseases, tubulointestinal diseases, urinary tract obstruction or dysfunction, recurrent kidney stones, untreated kidney stones, congenital defects of the kidney or bladder, unrecovered acute kidney injury, and certain medications, including non-steroidal anti-inflammatory drugs, calcineurin inhibitors, and antiretrovirals. Now, what are our concerns when we are dealing with patient with underlying poor renal function? So hyperkalemia, because the potassium excretion of potassium does not take place. Systemic hypertension, which may be the cause or the effect of chronic renal disease. Proteinuria resulting in hyperproteinemia, which has an impact both on the binding of anesthetic drugs and, of course, the healing of the wound in patients. Coronary artery disease. Now, the commonest cause of mortality in a patient of CKD is coronary artery disease. It practically coexists in a patient with CKD, especially a long-standing chronic renal disease. Anemia, because of the impact of uremia on the hemopoietic system, and these patients tend to have HB even in the range of 5.5 to 7.5. Hyperlipidemia, uncontrolled diabetes, as I said, is quite commonly the reason for patient having poor renal function and the main cause in the developed Western world. And hyperphosphatemia, because of the role that kidney plays in the calcium and phosphate metabolism in our body. Now, when we go further discussing the anesthetic concerns, one of the first ones is hypertension, and these patients are more often than not on 2 or 3 medications for control of blood pressure. Many of them may have had a history of hemorrhagic stroke, so that needs to be evaluated to see if there is any deficit because of that. Comorbidities like hypo or hyperthyroidism, rheumatoid arthritis, pulmonary disease, and such, if they are there, should be evaluated and optimized. In the last 1.5 years, we have seen quite a few patients with compromised pulmonary function as a result of COVID. Impact of uremia in various body systems need to be evaluated well, especially for us as anesthetists, the sensitivity to muscle relaxants, because uremia tends to cause myopathies. We have to take care of the anemia. Most of these patients are on erythropoietin stimulating agents, and the side effect of erythropoietin stimulating agents are that these patients are also a high risk for deep vein thrombosis and pulmonary embolism. So we must take an appropriate history, and where required, a low limb Doppler should be done if we are suspecting that patient may be having a deep vein thrombosis, and this has, as we all know, a very sinister outcome. Thrombocytopathy, so platelet numbers of platelets, the count may be normal, but the functioning is impacted due to uremia. This is of concern in centers which use still like to use neuraxial anesthesia for kidney transplantations, because of poor platelet function with other abnormalities of coagulation can result in a neuraxial hematoma, and which is a very dreaded complication because it can result in paresis or paraplegia. Diabetes is the other major comorbidity that we see in these patients of CKD. We look for an HbA1c of 7.5 or less. Diabetes has an impact on surgical site infection, and also these patients are given Solimedrol for transplantations. If diabetes is poorly controlled, then there are further high spikes in the sugar level and very poor glycemic control. So this has to be well controlled. Because CAD and CKD practically coexist, so a cardiologist is involved in the perioperative management, where we pick up a history or there is any finding in the ECG. If the patient has a poor MET, then we must look for a better evaluation with a dobutamine stress echo. Patients who have been listed for deceased donor transplantation should be evaluated at regular intervals so that they are in their optimal condition as and when the kidney becomes available. There is very little time available from the kidney being available and the patient coming on the table for kidney transplantation. So these patients should be adequately worked up, and the evaluation should be filed so that it can be assessed as and when kidney is available. Then is the patient on blood thinner? Again, because of the prevalence of CAD in these patients, many of them may have had a CABG, or they may be having a cardiac stent, 1 or 2, or Y stents. So if it is a recent stent, or patient has multiple stents or Y stents, then a risk-benefit analysis on perioperative continuation or discontinuation of dual antiplatelet. If you discontinue, there is a risk of stent thrombosis. If you continue, then it can become a nightmare for surgeon. But there's a lot of publications now in literature where kidney transplantations and even liver transplantation has been done on patients on dual antiplatelets. So appropriate risk-benefit analysis and shared decision-making with the patient, caregiver, and the surgical team. And this should be documented. Is the patient on ATT? Many of them are. So of course, we must know when the ATT has been started, what was started, and is there any impact on the liver function? Is the disease well controlled? So that aspect should be taken care of. How is the venous access? Most of these patients have poor venous access because they have been pricked several times for drawing of sampling, or they may be having an HD line, or HD line may have been placed a couple of times. AV fistula, which may have failed, and surgical access may have been tried once or twice, and so evaluation of venous access is very important. If the patient has an HD line in place, it's a good idea to use that line in the same side, jugular or subclavian on the same side, instead of taking another line on the opposite side, because whenever there is an indwelling line, there is always a high risk of thrombosis on that side. So it's really not a good idea to again put another central venous line on the other side. HD line can easily be used for monitoring of CVP and for infusion of fluids, but with strict asepsis, because we do not want to compromise that. Femoral venous cannulation is usually avoided because of the risk of infection, and definitely never on the side where the kidney is being transplanted, which is the right external right side. So right external iliac veins are used. So we mostly avoid a femoral vein cannulation. Is it a preemptive transplant? So the advantage is that these patients may not have had dialysis, would not have had dialysis most of the time. So the associated comorbidities associated with dialysis are not there in these patients. However, these patients will be volume overloaded. They may be acidotic. The potassium may be on the upper side. So after when the patient gets admitted for transplantations or a day or two prior to transplantations, again, we must assess the acidosis in the patient. And if we feel that there is considerable acidosis or very high potassium levels in the ABG, then 1 or 2 sittings of dialysis must be done in these patients before we take them off for transplantation. It is a joint responsibility of the team to inquire and evaluate for any focus of infection, whether in the urine, tooth, joint processes, any low-grade fever, sinusitis, or nail bed infection. Now, as far as urine is concerned, it is part of the transplantation protocol. Actually, all of them are, but sometimes they tend to be missed. So please inquire the patient during the PSC of any such infection hibernating in the patient. And patient might not have given this history to the primary team, which is a nephrologist and the urologist. Gynecological evaluation, again, a part of the transplant workup, but to inquire about the last menstrual period of the female patient before we accept them for anesthesia. A repeat CBC, coagulation profile, and renal function tests are done after the last dialysis, which is 12 to 24 hours prior to the transplantation. We want a patient with an HB of at least 6.5, and all the coagulation parameters should be normal, and potassium should be less than within the range which is for your institution. If the potassium is marginally low, then in these patients we do not try to correct the potassium, or because it may go on the other side. We note the preoperative blood pressure trend and profile of the recipient. We obtain an informed consent stating the risk. It should be within the 24-hour timeline before surgery, because each and every clinical condition must be stated in the consent. This has a legal impact. Vital measurements in the preoperative area, or what we say immediate preoperative assessment, which is also part of NABH and JCI mandate, must be done. The most important reason is that, one, that these patients can be sick to begin with, or there may be an effect of immunosuppressants in the form of tachycardia, a slight fall in saturation, sweating. So these should be attended to before we take the patient for induction. Induction can be done with graded dose of propofol. They are very sensitive to both hypnotics and narcotics. The preferred drugs are low-dose, short-acting narcotics, isoflurane and desflurane for inhalational as inhalational agent. Isoflurane and desflurane are used and not sevoflurane, because sevoflurane has a metabolism of up to 5% in human body, compared to isoflurane and desflurane, which isoflurane is 2% and desflurane is, I think, 0.2%. Atracurium or cis-atracurium is the muscle relaxant of choice, because they undergo Hoffman degradation, are not dependent on kidney for their excretion. Rapid sequence induction has been recommended in this patient. Idea is to keep the induction smooth and quick, as these patients have gastroparesis as a result of uremia. So they comprise a group of patients which are a very high risk for pulmonary aspiration. Antibiotic prophylaxis before surgical incision just before timeout. This is a WHO part of WHO safety checklist. So just like for other surgeries, patient should be given an antibiotic before incision. And it should be documented with the time and the dose. We avoid peripheral and central line cannulation on the same side as an AV fistula. You must remember that this is a surgical procedure. So there's a surgery involved and the cost involved. And we go with the premise that if transplanted kidney has a few hiccups, or if there is an ATN, or if there is rejection, then patient might require dialysis even after transplantation. So the sanctity has to be maintained. We usually cover the AV fistula with a soft gauze and label it, and we don't use that limb for any peripheral cannulation or blood or placing an NIBP cuff. Strict asepsis whenever we start a central line cannulation. When we use HD line if present, as I mentioned earlier too. Secure the lines very, very well in robotic transplantations with a single lure connection under the concealed area. There should be only one connection, and the anesthetist should be aware of where the connection is. Because in case this connection becomes loose or comes off, then it can result in bad flow of blood and making a patient bleed, because some of these lines are quite big, larger gauge, or the loss of fluid and any anesthetic agent that you're giving as an infusion. So this should always be kept in mind. In case of life-saving emergencies, AV fistulas can be used. Now, let's come to invasive monitoring and the risk versus benefit. Most teams prefer a central venous pressure monitoring. Arterial cannulation only if patient has a low EF and CAD or CAD, and in cases of robotic transplantations. So robot assisted transplantations, the problem is that the access to the patient is poor. We cannot make changes once we have handed over the patient to the surgeon. So we put in an intra-arterial line. It helps us in looking at the blood pressure, and also helps us in repeated sampling to look at lactates because or potassium, because these transplantations tend to be of longer duration compared to conventional open renal transplantation. Cardiac output measurement with control-based devices like Vigilio are being used in some centers, not in ours. Kidney transplantations are not a very long duration surgery. Mostly the procedure ends within 3 hours in a case of open, or 4.5 hours or 5 hours in case of a robotic transplantation, and patient is invariably reversed and extubated. So, and these devices do not work in a patient. Their parameters are not, cannot be dependent upon in a patient who is breathing spontaneously. So many studies, I'm sure, as anesthetists, you are aware, which support that CVP does not correlate well with the fluid status, more so in case of patients with end-stage renal disease. They have soggy lungs, they may have poor LV function. There is no ideal range which has to be maintained. However, a central venous line is inserted in most of these patients, and we must remember that there is an impact of IPPV and PEEP on the CVP. There is an impact of retractors and MOPs on the CVP. So usually we look at the CVP and we bring it up by another 3 to 4 by giving fluids. We do not give too much fluid for the patient, because there's some volume which goes with the ATG, which has been given 100 ml with Solimetrol, which is also running before the kidney, the transplantation starts in the OT, or the kidney comes in and the vascular anastomosis starts. On top of that, we can give about maybe 750 to 1 liter of fluid. And I find that this amount of volume is more than sufficient if the anastomosis is good and you have kept the pressure at good. That means that the BP should not be on the lower side. That is why I said that you should see the trend that patient has been maintaining, and we try to keep the blood pressure at that level for good perfusion of the kidney. We must also, as anesthetists, be aware about any tricky transplant, in difficult transplantation. So that sync with the surgeon has to be there. It is the surgeon responsibility of the surgical team and ours to inquire before surgery. And that is why in the WHO safety checklist, if you see, there is a column which says that is it a routine procedure or not. So then that is where they call out and say that, okay, patient has 2 arteries or veins and may require a bench dissection. So if a bench dissection is planned, it's good to maintain the patient as it is and not start giving fluid till the kidney, the venous anastomosis has started. No point keeping a loaded patient for a long time. Lactates and serum potassium levels are clinically important parameters. Intraoperative sugar levels to be monitored hourly in patients on insulin infusions. And we watched for intraoperative hypoglycemia. This clinical condition is not easy to pick up in an anesthetized patient, so we should be very aware of this condition, and we must watch out for it. And the best preventive measure is by doing hourly sugar levels. Blood and blood products must not be used liberally. There is a very high threshold because we do not want to add to the antigenicity of the patient. In our institution, we use leukodepleted packed red blood cells, and however, in many centers where leukodepleted is not present, then PRBCs are used. But as I said, that there should be a very high threshold for transfusions. Keep the patient warm. Transplant theaters are always very cold. But the patient's core temperature has to be maintained because of the impact of hypothermia on coagulation. Generally, we do not want the patient shivering when the patient wakes up. Intermittent pneumatic compression devices for lower limbs to prevent deep vein thrombosis. Dobutamine is preferred in patients with low cardiac output at low dose, and it can be combined with noradrenaline. Vasopressors and inotropic agents are rarely used. If you manage your anesthesia, especially the inhalational agents, the narcotics, and the fluid well, then we rarely ever use vasopressors and inotropic agents in kidney transplantations. So the problem why there is an apprehension for vasopressors is, though they can bring up the blood pressure for you, but you must remember the potential for renal vasoconstriction, and we definitely do not want it in this group of patients. Fluid therapy, again, literature is full of which fluid is best in a patient of kidney transplantation. There are pluses and minuses for all of them. So there are colloids, we know the controversy, and we know about the bleeding complications. Albumin, there is cost, potential for anaphylactic reaction, potential for infection. Saline can cause hypochloremic metabolic acidosis, acute kidney injury, increase in pro-inflammatory mediators, etc. And balanced salt solutions now, for the last 10, 14 years, they are being used increasingly in most of the centers. Some of them tend to alternate balanced salt solution with saline. We prefer to use balanced salt solution in our center. In robotic transplantation, the added challenge is that patient is in a head low position. This head low is not as steep as we see in a robotic prostatectomy. However, this adds to facial swelling and edema of the airways. The uvula may become very swollen and result in obstruction when you extubate the patient. So because you must always remember that these patients have a lot of interstitial fluid because of the kidneys not functioning before the transplantation. So when the robotic arms come off and surgeons begin to close, we give a 40-45 degree head up in these patients and continue the positive pressure ventilation with few lung recruitment strategies. And this usually takes care of this edema, and it is easier and smoother to extubate these patients. We always avoid postoperative ventilation. So compared to other solid organ transplantations, less pulmonary infection has been seen in a patient of kidney transplantation who have been ventilated, but the outcome has been found to be poor. So some references for you to look into them. So the main emphasis in the intraoperative and the postoperative period is the management of volume status, because now the kidney is recovering and we must match, and the patient should be on the plus side, otherwise patient goes into AGN, mostly based on urine output and starts on table as soon as the transplanted kidney starts producing urine. There's no recommendation or algorithm as which can be considered sacrosanct. Normally we match the previous hour's urine output and add. Many studies are there for use of mannitol and furosemide when the clamps come off, but there's no guideline as such. And in our center, true, we do not use either mannitol and very rarely furosemide after the vessels are unclamped. Management of immunosuppression is done mostly by nephrologists in most of the centers, and as in ours. I will not go into details of this because this is a completely different, this requires several lectures, I guess. We do look at tacrolimus levels in these patients, more so if they complain of any chest discomfort or we see any arrhythmias, because and other symptoms, dizziness, nausea, vomiting, because tacrolimus levels have to be watched for in the postoperative period. Chemothromboprophylaxis for DVT always done after discussion with the surgical team, because their concern for bleed from the surgical site should always be kept in mind. 40 milligrams of enoxaparin given subcutaneously once a day is the protocol that is followed, and it is continued till the patient is completely mobile. Management of postoperative surgical pain, one of the mainstays is paracetamol. Patient control analgesia pumps, IV patient control analgesia pumps can be used where the patient is in control of the dosage that patient can take. And we use short-acting narcotic. The only short-acting narcotic available in India is fentanyl now. So we never run it as a continuous infusion. When we combine it with ultrasound-guided blocks, then we find that the consumption of fentanyl is absolutely minuscule in the first 24 hours. So the ultrasound-guided blocks which we use are transversus abdominis plane block and quadratus lumborum block. So this is a video of the sonar anatomy of quadratus lumborum. So this is the psoas muscle here, and this is the quadratus lumborum muscle, and these are the rectus spinae group of muscles. So we bring in the needle from here and we deposit the drug between the psoas and the quadratus lumborum in this plane, and it is postulated that this passes through the muscle planes and enters the paravertebral space, giving us the analgesic effect that we want. This is the sonar anatomy of transversus abdominis plane block. This is the external oblique muscle, this is the internal oblique, and this is the transversus abdominis. We deposit the drug between internal oblique and transversus abdominis muscle in this plane. This is where the neurovascular bundle runs, and this gives very good analgesia for patients of renal transplantation. Some patients, if they complain of chest discomfort or pain, we look for, we evaluate the patient for any adverse cardiac event. So as I said earlier, that we do look at tacrolimus level, and then we also get baseline cardiac troponins done, and we have to see the trend in troponin. It is very important here to mention that cardiac troponin levels can be elevated in patients of end-stage renal disease without any underlying adverse cardiac event. This is related to probably the metabolism of these troponins. To diagnose a patient with adverse cardiac event, one must clinically correlate the symptoms with any fresh changes in ECG, any fresh change in 2D echo, and of course, the trend over 24 hours of the troponin levels. There should be high alertness for graft dysfunction in the postoperative period. So the most important factor, of course, is the urine output. If there's a drop, we request for renal Doppler to look at the anastomosis that everything is fine. If you're suspecting a hematoma, then a sono of the abdomen to rule out. A manned OT always on standby in any unit performing organ transplantations. In our theater, the transplant suite is just next to the operation theater, so that patient can be taken in within 30 minutes. Challenging to differentiate between rejection and sepsis in the early stages. The most in a nightmare scenario is because for rejection, steroids are given to the patient, and that can completely worsen the outcome in sepsis. So this requires very careful and astute assessment and management. And at the end, I would like to say that renal transplantation is a teamwork of nephrologists, urologists, anesthesiologists. We play a very important part in renal transplantation team with a lot of input from cardiologists, pulmonologists, endocrinologists, physiotherapists, dietitians. So it is a very closely working team, and because as they say, none of us is as smart as all of us. Thank you very much, and I hope this lecture helps you in your clinical practice. Have a nice day.